Good afternoon, everyone. Thanks, Dr. Meet, for all those kind words. At the offset, I am extremely thankful to entire organizing team of Diabetes India 2020, in particular, Dr. Bansi, Dr. Jyoti, Dr. Manoj, Dr. Arvind, and Professor Mishra for this opportunity. And task assigned to me is to discuss about whether we have CV outcomes today in 2020 and whether these are relevant to us in practice of diabetes management. Thankfully, it is not a debate, so I'll be able to give you a very, very balanced opinion on that. And over next 20 minutes, I'll try to do justice to the session which has been allocated to me. We all know that approximately 50% of people with type 2 diabetes still die from cardiovascular disease. Having said that, type 2 diabetes is a severe risk factor that determines the need for cardioprotection. So very rightly, European Society of Cardiology, minded it is Society of Cardiology talking about anti-diabetic drugs for the first time, said that individuals with type 2 diabetes and CVD or diabetes with target organ damage or 3 or more major risk factors are at a much greater risk. So AD and ESD also since 2019, 2021 in joint consensus said that all those patients with established atherosclerotic cardiovascular disease or indicators of atherosclerotic cardiovascular risk, heart failure, CKD, should ideally be on SGLT2 inhibitor, GLP-1 receptors with demonstrated CV benefits as part of glucose lowering regimen. So let me give you the background why these CV outcomes have become important. The effect of tight glycemic control on CV complication range from neutral to perhaps harmful, as was seen in a ACCORD study, which ended up with higher cardiovascular mortality, and it was stopped before the completion of the study. Since then, we know many studies, where earlier studies also like UKPDS, where it has shown that individual medication on diabetes complications, they had a mixed response. So those patients who were on metformin, there it was seen that there was not only reduction in MI, diabetes-related deaths and all-cause mortality by almost 39 to 40%. Even 10 years follow-up of UKPDS has shown that metformin-treated obese patients with type 2 diabetes continue to have a reduction in MI and death from any cause by almost 33%, although numbers were very small. Well, TZs, specifically talking about pioglitazone in proactive study, which enrolled 5,000 patients, it was shown that it improved CV risk factors and significantly reduced the second principal MACE endpoint by 16%. However, the composite primary endpoint didn't reach a p-value-wise significance. So when we talk about CV outcome trials, we know in 2007, a meta-analysis of 42 studies has shown that rosiglitazone ended with increased risk of MI, and that hinted for the first time that there could be a CV-related death as a result of the drug. That prompted FDA announcement in 2008 that a meta-analysis of CV events during phase 2 and phase 3 studies must be included in applications submissions for glucose-lowering therapies. So fortunately, now large phase 4 trials have become almost culturally mandatory because no company wants to have a disadvantage of not having a post-marketing safety, even in spite of getting a US FDA approval. So 2008, for the first time, US FDA released guidance for the industry. It said that sponsors should demonstrate the therapy will not result in an unacceptable increase in CV risk, even if pre-marketing analysis has shown that hazard ratio could be less than 1.8, so drug could be launched, but subsequently the post-marketing analysis has to establish that hazard ratio for any cardiac event has to be less than 1.3. So it also mandated that meta-analysis strategies using phase 2 and phase 3 data should be included. It also mandated that blinded central adjudication of all CV events should be there. It also said that there should be an inclusion of high-risk subjects like advanced CKD, CVD, and elderly patient, and there should be a minimum exposure of 2 years in large CV outcome trials with a 15,000 patient years data. There are 3 common ways of representing cardiovascular outcomes, either by assessing time to occurrence of cardiovascular outcomes or by performing a survival analysis or by summarizing treatment effects through various statistical methods. But mind it, there could be a misinterpretation of statistics that can affect clinical practice because of differences in baseline cardiovascular risk levels of population between different studies. And it is crucial to take into account differences in study design, length of follow-up. There could be too much heterogeneity in enrollment of those patients. We know over last century there has been an evolution of diabetes therapies from early days in 20th century, where we were talking of primarily of drugs simply to reduce carbohydrate load in form of some Ayurvedic drugs and lifestyle modification. But in 1959, for the first time, we saw launch of biognoid metformin, and 1956 sulfonylurea, primarily tolbutamide. But since then, there has been a large armamentarium of drug which has been added over last 75 years. Since the FDA alert in 2008, 13 years have seen 15 CV outcome trials. And by end of 2018, we had launch of almost near DPP4s, SGLT2 and GLP-1 like analogs. And there has been one comparative insulin trial trying to compare to insulin. But good thing is none of these trials, they have reported an increase in risk for any major cardiovascular event or MACE, and actually 6 agents have demonstrated CV benefits. So it all depends at what stage and what type of population you are enrolling. If you are enrolling a population with end stage with end organ damage, like what was done in EMPEREG, you might see much better results. But if you are just considering vascular risk factors, what was done in Excel, TICOs and Freedoms, then obviously results may not be very, very impressive. But if you are primarily enrolling a primary cohort, what was done in DECLARE-TIMI, obviously 3-point MACE didn't come out to be very, very significant. Here is a snapshot of all non-insulin CV outcomes till date. Mind it, the bubble size represents the total population. And you could see that DECLARE-TIMI had primary cohort with only multiple risk factors and established disease only in 40% of patients, while the upper box, you may see these are primarily those trials there they have enrolled established atherosclerotic cardiovascular disease or event patients. And in the credence, you had primarily those patients who had EGFR less than 60, while the upper right box shows you patients, those who have both established atherosclerotic cardiovascular disease along with reduced ejection, with reduced EGFR. So evidence from CV outcome has shown that there could be some glucose lowering therapy which will have beneficial effects on CV outcomes, but it all depends what type of drug you are enrolling. And you could see that when we are talking about SGLT2 inhibitors like EMPA or Canibus, we not only had 3-point MACE reduction, but we also had significant reduction in hospitalization with heart failure by almost 35%. When it comes to GLP-1 like analog, there you could see that benefits on heart failure are neutral, but there were benefits in terms of 3-point MACE reduction. But with the DECLARE-TIMI, because it was primarily a cohort with lesser atherosclerotic cardiovascular disease or risk, so benefits in terms of 3-point MACE was neutral. And so was with DPP4, because those drugs are classically CV neutral. But in the severe TIMI, actually it was seen that there could be increase in hospitalization with heart failure. So all primary endpoint in CV outcomes of type 2 diabetes since 2016 have established that individual drugs may mechanistically differ in their impact on CV outcomes. No particular endpoint could be seen as a gold standard for all CV outcomes for glucose lowering drugs. So 3-point MACE primarily is likely that this could be the best option for looking into the endpoints. So navigating the MACE in cardiovascular endpoints, most important lesson learned from CV outcome is that classic MACE endpoint may not accurately capture the magnitude of CV morbidity as well as mortality. CV benefits of GLP-1 receptor agonists we have already seen are primarily on those patients, those who have established atherosclerotic cardiovascular disease, and they might have benefits in some of non-fatal MI, non-fatal stroke and CV death, while with SGLT2, primarily benefits are in terms of hospitalization with heart failure. CV outcome results have also highlighted the major role of heart failure per se as an independent of atherosclerotic cardiovascular disease. So further studies possibly will focus on potential synergistic benefits and the cost effectiveness of both the drugs like SGLT2 inhibitor as well as GLP-1 in management of type 2 diabetes. And CV outcomes have definitely helped us navigate the maze of other complex nature of CVD, not only in terms of atherosclerotic cardiovascular disease, but also heart failure benefits in our patient with type 2 diabetes. When it comes to heart failure outcomes and CV outcomes with SGLT2, of course, there has been a significant reduction in hospitalization with heart failure and composite CV death and heart failure by almost 20 to 25%. Trials included almost 38,000 patients. And again, the magnitude of benefit from SGLT2 therapy on MACE was primarily modest on overall 3-point MACE, but it was primarily driven through hospitalization and heart failure and composite heart failure and CV death. While the effects of SGLT2 inhibitor on MACE are confined primarily with history of atherosclerotic cardiovascular disease, in heart failure, benefits are universal, irrespective presence of atherosclerotic cardiovascular disease. Despite the size of randomized sample and consistent benefits on hospitalization heart failure events, still, unfortunately, none of the tested SGLT2 inhibitors still has a label to be used for prevention of heart failure hospitalization in type 2 diabetes. And this possibly could be explained because of the fact that heart failure label indication is largely due to heart failure not being as a primary endpoint in all these CV outcome trials. So the future direction for heart failure and non-primary endpoints as far as CV outcome trials are concerned ideally should be that heart failure is present at baseline. So we must standardize a comprehensive characterization of heart failure. We must ensure the proportion of patients with baseline heart failure, which is actually reflective of presence of that comorbidity in routine clinical practice, not in higher risk group. When we have significant effects of agent on heart failure, which are likely or anticipated, then we should try to enroll patients with high risk for heart failure, and heart failure even should be included as a primary endpoint, not as an additional 3+1. Should unstable angina be included in primary endpoints? Well, there has been evolution of prospectively planned primary endpoints in completed CV outcome over last 20 to 25 years. Earlier days, we were talking of only hyperglycemia, risk of hyperglycemia, mortality, renal failure, and retinopathy and other things. But of late, we have been talking of unstable angina, heart failure, CV death, or composite of that. But when it comes to hospitalization with recurrent angina or unstable angina, we know the inclusion of angina increases the number of events for analysis. But then, minded, there could be disadvantages because of too much subjectivity in hospitalization with unstable angina. Moreover, CV outcomes indicate glucose-lowering agents seem to have minimal effect on unstable angina. So if it is included as a fourth MACE, then obviously there could be shift towards the null, because then benefits could be nullified by presence of unstable angina, where the benefits of SGLT2 may not be very, very reflective. The primary outcome of 3-point MACE may offer possibly a better balance between or better balance than 4-point MACE because of statistical efficiency and operational complexity, which is in favor of 3-point MACE versus 4-point MACE. And we know all these CV outcome trials, they try to enroll a much higher risk population so as to deliver the results in as early as possible within 2 to 3 years. That is why data from CV outcomes may not be applicable to vast majority of patients in clinical practice, what we see in everyday practice. So if you talk about the EMPEREG, less than 18% patient will match what has been enrolled in EMPEREG trial. Even UK Royal College of General Physicians research base has also shown that not more than 15% patient will resemble what has been seen in EMPEREG trial. So to answer that, here is a real world use and model impact of glucose lowering therapy, which have been evaluated in recent cardiovascular trials. So aim of this was to evaluate the current use and potential real-world impact of these drugs like AMPA and liraglutide among patients with diabetes collaborative registry, which comprise almost 242,000 patients. But minded, among patients with overt type 2 diabetes in this DCR registry, less than 26% patient would have been eligible for EMPEREG and less than 48% would have been eligible for LEADER. That means most of these CV outcomes may not be reflective of what is a real world practice. Then there are challenges when we talk about CVD. and CKD patient in CV outcome trial, normally it is thought that there is an intersection of risk factors amongst CKD as well as cardiovascular disease. Then there could be patient-related factors like volume overload, anemia, infectious, dyslipidemia. There could be practice and therapeutic-related factors which could again nullify the benefits because of bioincompatible dialysis condition. And there could be uremia-related factors and certain biomarkers which could change the overall logistics. So an ideal approach to precision medicine for cardiovascular outcome trials with CKD will be to identify target pathophysiology leading to cardiovascular events. Treatment should be then selected based on the mechanism of action known to modulate that pathophysiological target of interest. Biological markers should be identified, and then we should identify those patients with those markers of interest and conduct randomized controlled trials of specific therapy in patient with those particular pathophysiology. Another lacuna of CV outcome trial is that minority have been underrepresented. So if you talk about USA, where 13% of population is Black or African American, those who have almost 13 to 15% prevalence versus the Caucasian, which have only 7% prevalence of type 2 diabetes. But even in these trials like EMPA, Examine, Saviour-TIMI or ELIXA, TICO's leader or Sustain 6, less than 5% of this population, they were represented in these trials. This could be because of the fact that there could be a socioeconomic status in these minorities, so they are in a underprivileged state. So it could be also because of insufficient reliable transportation, poor health literacy among these patients, inadequate knowledge and overall nature of the medical research and disease that they are still not able to use these facilities. So coming to whether CV outcomes are equal and whether we can directly compare these outcomes, CV outcomes definitely aim to demonstrate the addition of a novel agent as safe as is usual care. That means it is non-inferior primarily. But unfortunately, most of these trials have been versus placebo. Trials have aimed for a glycemic equipoise. And we know that in current era of primary multiple risk factor management, like stenotype 2 management approach, CV events are already very, very low. So CV outcomes are primarily safety trials, and it is reassuring that outcomes to date, they support CV safety primarily. Patient at much high CV risk may be much lower in overall general diabetes population as compared to these CV outcome trials. So trials ideally should include lower population of patient at high CV risk, and that may be considered more representative of real world practice, what was done in primary cohort and declared TIMI. Then I told you there are limitations of CV outcome, lack of generalizability because of the fact that all population are not equally represented. These are too short lasting trials. 2 years may not get you benefits in terms of atherosclerotic cardiovascular disease. Then even time for getting harmful effects is too short. 2 to 3 years may not get you the true picture of harms which might come out of these drugs. And most of these trials are, I told you, placebo designed. These are not versus active comparator. So opportunities for improvement in CV outcome trials could be that we must include lower risk, more diverse population. These primarily should be primary intervention trial in lower risk population with a longer term follow-up of at least 3 to 5 years, and we should have an active comparator. But again, mind it, if we are using an active comparator, we should be sure of sufficient knowledge of that drug versus any CV impact, and we should have a standard definition of important safety as well as microvascular outcome. So if you ask me, is it time that we should abandon CV outcome trials? Possibly no. There has been a recent crescendo in enthusiasm for real world evidence, but we know that all real world evidences are non-randomized observation analysis, and they have inherent limitations for only circumscribed reduction of treatment effects. Real world approaches are usually confounded by indication, information, and ascertainment biases. So there is true requirement to assess each anti-hyperglycemic medication at least once in a large scale standardized CV outcome trial, and that should be then subsequently give the confidence to clinician in terms of both safety as well as efficacy of the drug. Thankfully, US FDA 2011 revised its guidelines for all these drugs. It today says that there should be at least 4,000 patient years of exposure of new drug in phase 3 trial. It should have 1,500 patients exposed to new drug for 1 year and more than 500 patients for 2 years. at least 500 patients with stage 3 or 4 kidney disease should have exposure of that drug, and at least there should be 600 patients with established atherosclerotic cardiovascular disease and more than 600 patients of older age, more than 65 years, to establish the safety of the drug. So CV outcomes are very, very important. It should be noted that when we are referring to CVD, we should not only include macro, but also microvascular complication and morbidity, because both are equally important. And new and existing glucose-lowering therapy should be evaluated not only for their overall effect on vascular health, including heart failure, as well as risk like amputation and others. CV outcomes have definitely sensitized diabetes care providers to the opportunities for multifactorial and comprehensive diabetes overall risk reduction. And we know CV outcomes have demonstrated cardiovascular benefits in further reducing CV morbidity and mortality. And these CV outcomes have definitely embraced these days more cardiorenal primary endpoints, and the trial design of CV outcome is robust enough to have allowed their results to inform current recommendation. Actually, it has made a basis for current recommendation and guidelines across the globe, but still it has to go a long way. We should include other microvascular complication like cardiac autonomic neuropathy, which has not been represented and it has not been explored in contemporary CAV outcomes. So to conclude, CV outcomes are important, but there is a huge scope for improvement into CV outcomes. We should try to enroll more like primary cohorts. We should also try to include plus 3-point MACE plus comorbidities like heart failure and other risks. And we should include CV outcomes with patient with CKD, elderly, and other comorbidities. Thank you very much for your patience listening, and stop sharing here and stand by for any questions and answers.